Hello, everybody, and thank you for coming to Strive's Q&A on coronavirus, featuring Dr. Amesh Adalja, who we are very happy to have back. Thank you for joining us today. Dr. Adalja is a senior scholar at the Johns Hopkins University Center for Health Security, and his work is focused on emerging infectious disease, pandemic preparedness, and biosecurity. We have gotten two pre-submitted questions from Margaret, so I will ask those first. If you have any questions, you can type them in the chat or raise your hand, and we can go in order and you can ask your questions. Here's Margaret's question. How to think about re-engaging with the world? As various states reopen, we're seeing an uptick in cases. This was to be expected. Reopening isn't predicated on the virus disappearing, but only on there being sufficient hospital capacity to deal with severe cases. What's a reasonable way to think about re-engaging with the world? As a family, we're still planning to social distance through the summer, though my husband will be returning to work on June 15th. Returning to work opens the door to our bubble, but we don't want to open it wider than necessary on the premise that it's hard to predict if your case may be severe or not. Long-term health impacts are not well understood. However, at some point, we have to resume participation in the world more fully, even before there will be a vaccine. That will likely be in September when our son returns to Montessori school. Even then, we're planning to avoid airplane travel and indoor social situations, such as restaurants, weddings, etc. Is this reasonable? Are we correct in continuing to minimize exposure? Or is it really that once we open the door, it's open, and there really is no help until there is a vaccine? So, as long as there is sufficient hospital capacity, is it sufficient to just wash our hands, wear masks, and let it rip?
So this is a hard question, and the reason it's a hard question is because it isn't going to be something that's black or white, that there's answers. That how we re-engage with society is going to be different for each person based on their own risk tolerances, their own preferences for risks, their own risk factors for severe disease. And you're going to really have to find people looking to see what's essential in their life, what's not essential, what risk tolerance they have. I'm somebody with a high risk tolerance, so I'm in Pittsburgh right now, and our restaurants are open, and I was at restaurants last night without any problem. I might be a little bit skewed because I'm taking care of patients with this, so I'm kind of a little bit numb to the risk, or not necessarily that scared of it from the sense of my own personal experience. But that's going to be different for each person, and I do think that you're going to have to realize that until there is a vaccine, that no activity you're going to do is going to be without risk, and that you're going to have to really try and navigate this the best you can. And there are some common sense things you can do, like avoiding congregate settings, washing your hands a lot, refraining from touching your face, trying to avoid mass gatherings. If you can travel to a place without having to be around people, in a car versus an airplane, for example, that might be something you want to do. But that's not going to be a one-size-fits-all decision. Every person is going to have to look at this in their own life and make a decision. And I think that there's ways to minimize the risk of that, but then you also are going to not be able to do certain things that you might have wanted to do. So I don't think that there's a way to come up with a formula. It's really going to be based on your own risks, just like the way you deal with the risks every time you step out the door with other types of health issues that might arise anytime you interact with other people or when you do something. And it's not going to be easy, and most Americans have not had to deal with this for over 100 years, this type of infectious disease risk that's out there. But that was what was going to happen when you had a virus that spreads in this manner, established itself in the human population for which we have no vaccine or no strong, effective treatment.
Thank you, Dr. Adalja. I believe the next person who wanted to ask a question is Ricardo, followed by Dr. Ellen Kenner, and then Tyler.
All right, so now less than 1% of Americans have been confirmed to tested positive for coronavirus. So now that things are starting to reopen, won't there just be like a second wave And assuming that states adopt like another lockdown type policy, won't it like never get to like 50% or whatever herd immunity is?
So it is the case that as people social interact, this virus is going to take advantage of that opportunity and transmit from person to person. And we will see periodic outbreaks and increasing cases all over the country on an asynchronous basis, depending upon what's going on in the specific geographic area. And that was to be expected. The issue is that now we have hospital capacity to deal with those individuals that may require hospitalization, and that puts us in a much better place. It is not likely that we're going to get to herd immunity before a vaccine. I think we will get some pockets of the country may get to herd immunity. Herd immunity threshold is probably around 60% for a virus like this. I don't think we're going to get there until there is a vaccine. So people are going to remain susceptible to this virus. I don't suspect that you're going to see lockdowns again. I don't think that there is the political will to do that again. What you might see is very targeted types of things happening, saying we're going to recommend that we're having a hard time in our hospitals right now, so we're going to recommend that people stay home, or we're going to decrease the capacity at restaurants. That type of thing might happen. And remember, most places are not going to be having big mass gatherings like sports events with fans. So I don't think we're going to get inundated again, because everything is being very measured. But it is the case that we likely will not reach herd immunity until there is a vaccine, because there are so many things in place. And people, even if there aren't lockdowns, so many people are still social distancing, just like as you heard in Maggie's question that people are still continuing to cocoon themselves away. And that's going to impact when we get herd immunity. And I think it's a good thing that we're going to wait. I think it's not a bad thing that we're having to wait for the vaccine to get herd immunity, because when you go after a herd immunity strategy, you do rack up a sizable number of deaths.
Thank you, Dr. Adalja. Our next questioner is Dr. Kenner. So Dr. Kenner, you can unmute yourself and ask your question.
Hi, Amish. This is Harris's question, actually.
Oh, let me read it now, since too much time has passed since
It's
I
right here.
created. Oh, is it dry heat or moist heat that damages the virus, and what is the biochemical mechanism?
So this virus is a coronavirus, and remember, it's the 7th human coronavirus that we've discovered. So it has a lot of the same biological characteristics of the other coronaviruses. And when we talk about heat, so in general, this virus is very fragile because it has what's called a lipid envelope around it. So a kind of fatty surrounding, and that fatty layer needs to be moist. And so when it can get dried out very quickly. And what we're really talking about is more dry heat than wet heat. Although it will get disrupted by water if you boil it or something like that, it's not that something that survives is viable in the environment for any long period of time. So it really doesn't matter if it's any kind of heat is going to denature it and disrupt that lipid membrane around it. In general, when you have a virus that has these lipid envelopes around them, they're very fragile in the environment versus something that doesn't have an envelope. And a good example of that would be the norovirus, which we hear about on cruise ship outbreaks, which are notoriously hard to control because that virus remains viable. It's harder to disrupt that virus with detergents and soap or anything like that.
Taylor, you can go ahead and ask your question now.
Thanks. Dr. Adalja, early on, even back in, February, people were talking about the possibility of coronavirus coming back in the fall. Do you know what the current state of knowledge is on the possible event and what it might look like?
So we do expect this virus to remain with us, because this is something that's established itself in the human population. It's not going to disappear. And we know that coronaviruses have this seasonality where they tend to intensify their transmission when it is colder. So I do think it is basically a simple fact that we will see cases of this through the fall, and we will be contending with this at the same time as influenza, and that there is good reason to believe its transmissibility will be increased during a period when it is colder, when it is less sunny, when it is when the humidity has changed. So I do think we will be dealing with this in the fall, just like we deal with other coronaviruses every fall as well.
I believe that the next person in line is Audrey. If you would like, I'm not sure if I'm pronouncing your name correctly, but you can go ahead and ask your question.
Doctor, yeah, I measure my temperature under the tongue in morning and evening, and it goes from 95.8 till 98.2. Is that as good as a is that a good test as a positive negative swab test?
So temperature measurement is one. Many of the people that have this virus do have a fever. It's important to remember that not everybody that is infected with this has a fever. So the swab test is actually looking for the genetic material of the virus. So it is a much more sensitive indicator of infection than a fever. And oral thermometer readings are not necessarily that accurate, because you can have a cold drink and it's going to affect the oral thermometer reading. So it's a screening test, but it's not a very sensitive screening test. Obviously, if you have a fever, you have a fever, and that's something important to know. But I wouldn't say that that's the same thing as a nasal swab test. No, not equivalent.
Okay, thank you, doctor.
So the next question is my question that I would like to ask. I'm curious about the way that the virus actually affects the human body and by the means by which it kills its victims. It seemed to me at the beginning of the pandemic that ventilators were helpful for treating severe cases, but evidence I've seen since has made me question just how effective the specific treatment is. In what way does the virus affect the body such that it produces such a diversity of symptoms? I realize that there's still many unknowns, but I would like to have your thoughts on this topic.
So with any infectious disease, there's going to be a spectrum of illness, and it's going to depend upon who's being infected. So there's going to be this very wide range depending on what the risk factors are for severe disease. But in general, what this virus is, it's a respiratory virus. It affects the cells in your respiratory tract, causing pneumonia, causing your lungs to become inflamed, and it has an interaction with the immune system. All infectious diseases are both the pathogen and the immune system together causing the symptoms that you have. And when this kills people, the primary way that it's doing it is that it's causing the lungs to fail by creating a pneumonia that's then reacted to by the immune system, and a lot of tissue damage can occur there, and people are unable to oxygenate their body. When you get that sick in the hospital and you're on a ventilator, there's lots of other complications that can happen as well with any kind of critical illness. So you can have multiple organ systems infected or affected, like your kidneys, the heart, other things can do it. But the primary mechanism is usually people are dying from respiratory failure because of inability to oxygenate their lungs. There are people that do get strokes and have blood clots in their lungs and other things, but those are not the primary means that people are dying. Some people do die from those complications, but most people, when they die from this, are dying from the respiratory failure that occurs. And that's why, so with ventilators, just to go on there, it's important. We always have known that ventilators can cause damage to people, and you have to be judicious about when you're using them. And with this infectious disease, there was a little bit of misunderstanding about when to use the ventilator. And there were some people who had really high compensation to the low levels of oxygen, didn't really require a ventilator, and we didn't want people to be just pulling a hair trigger to put them on a ventilator. We wanted to actually evaluate the patient, and can they be managed with supplemental oxygen through a nasal cannula or through a BiPAP, CPAP machine, and that's what was happening. And this is something we see with other infectious diseases too. It's just getting a lot of coverage because of the nature of the pandemic.
Thank you. The next person in line is once again Ricardo. So Ricardo, you can unmute and ask.
So could you comment on the current state of hydroxychloroquine? And also, could you also comment on, these studies that have been coming out that allegedly prove that it's positive or allegedly prove that it's negative? And we seem to have this like flip-flop somewhat constantly. Could you comment on this whole thing?
Sure. So just some context on hydroxychloroquine first, and then I'll go into that. So hydroxychloroquine is a drug that's been around for a long time. It's approved for certain autoimmune conditions like rheumatoid arthritis as well as malaria, just like chloroquine, which it is derived from. Hydroxychloroquine does have what we call immune modulatory properties, meaning that it changes your immune system, and it also has some direct antiviral effects in vitro, which means in a test tube in a lab setting. So there have been people trying to use hydroxychloroquine for different viral infections for some time, and none of it has been definitive. during the early days of this pandemic in China, there were individuals in China that were using hydroxychloroquine, and they were kind of getting mixed results. But we didn't really have we didn't have results from a randomized control trial. We had a lot of anecdotal and observational data, which was kind of mixed. Most of it not done in well-controlled studies. Then, in the United States, there were protocols to use it. There was a lot of hype around using it, and we've been in a process now of studying it. And there has been some data that's come out, observational data, that has shown that doesn't really show anything very promising. However, there was a prominent paper that just got retracted from the Lancet because there was some fabrication of data. So that doesn't help us show that, and this was using it in a different type of, this was showing a lot of side effects that were occurring, but it doesn't seem that data, we could rely on that data, so that's been retracted. So the jury is still out on hydroxychloroquine. My professional opinion of hydroxychloroquine is that it does not appear to have very strong effects on this virus, either definitely in a post-exposure. If you've been exposed to the virus, I don't think it's going to help you ameliorate you from developing it. And I don't think that there's much benefit in the people that have had this illness and have gotten hydroxychloroquine, especially those in the hospital. I do think that I want to reserve the right to revise that when we see proper randomized controlled data on the drug. I think it should be still studied, and I think that we'll get some information on the prophylaxis doses, because we are doing a big trial in healthcare workers where they're on hydroxychloroquine to see if see how this affects them. But right now, I don't think that this is something I would routinely give people. I myself have prescribed it to 2 different people according to hospital protocols in hospitalized patients. But I think that this is something that I would not. I don't expect we're going to see much of a benefit from hydroxychloroquine, despite a lot of the interest in it. I think that remdesivir, which is another antiviral that got emergency use authorization from the FDA, that likely is the only antiviral we're going to have for some time that has an impact. And also, one last thing about hydroxychloroquine, it's important to know that it does have side effects of heart rhythm disturbances, and you want to monitor those individuals that are on it with EKGs so that they don't develop heart rhythm problems. And it's not the idea that anytime you give a drug to somebody, it depends upon what the condition you're giving it for. And it's not the same thing to give a person hydroxychloroquine for rheumatoid arthritis or lupus versus giving it to them for the novel coronavirus. There is a different side effect profile depending on who you're giving it to. So I think that's important to remember as well.
The next questioner is Mugat, who has had their hand up for a while. If you would like to unmute, then you can go ahead and ask your question.
Okay, my question is, if money is not an issue, what kind of medical equipment shall I buy to deal with a serious case of COVID-19?
Are you talking about for yourself, or if you're a hospital, hospital CEO, or your
well, if I want to be completely independent of the medical system and just have serious medical equipment and to deal with an emergency where there is a run on the system and I have to take care of myself.
So I've never been asked that question before. I think it would be very hard to do that. I mean, most cases of coronavirus are mild. They don't require hospitalization. Those that require hospitalization sometimes will require supplemental oxygen. So that's like an oxygen tank and a nasal cannula. Severe cases might require a BiPAP or CPAP machine, IV fluids. In very severe cases are going to require a mechanical ventilator. I don't think these are things that you can have in your home other than supplemental oxygen, which we do give to people with, for example, lung disease like emphysema. I don't necessarily think that I wouldn't recommend that people try to do this on their own. There are dangers with trying to administer that equipment on your own without the supervision of a doctor, at least the guidance of a doctor. Some of those things are flammable, for example, those oxygen tanks. So I would just be very careful about doing that. But those are the kinds of medical equipment we use on individuals that are sick, but it's very dangerous to use this outside of a supervised setting without people who know how to operate that machinery in place.
The next question is another pre-submitted question from Margaret, and she asked, what are reasonable improvements in disease management that can happen before a vaccine is created? I.e., what are we waiting on or hoping for? I'm thinking that better therapies might emerge, better handling by health facilities, better supply of PPE, better understanding of at-risk populations, such as by blood type, and so on. Would love more color on that.
Definitely there are going to be improvements, and there already have been improvements over the last 4 months or so in terms of how we treat these individuals, in terms of understanding who benefits most from a mechanical ventilator, when to put people on a mechanical ventilator, what are the alternatives to mechanical ventilators. We do have one antiviral drug that has shown some effect in getting people out of the hospital faster, called remdesivir, which is now available. We have gotten better at understanding the risk factors. So for example, we really understand that hypertension is a major risk factor for death. It increases your rate of death about twofold. So this is something, so we are getting a lot of granularity there. We've gotten much better at diagnostic testing. It's a whole world better than what it was in March now. We're doing about 400,000 tests per day in the United States. We are learning a lot about transmission and where transmission occurs and when it doesn't occur. So for example, we're really a lot of focus on household transmission. We've gotten much better at contact tracing. A lot of health departments have hired armies of contact tracers to help keep those cases down to a minimal number when you can actually you can track, trace, and isolate those individuals who have been infected or exposed. So, and there are some other antivirals in addition to remdesivir that are in clinical trials. We hopefully will get more randomized controlled data on many different compounds that are out there that may help us decrease the mortality and decrease hospitalization time and decrease the complications. So I do think we will probably see improvements prior to a vaccine as well.
Thank you. The next question is again from Ricardo, so you can unmute and ask.
Would you comment on countries such as India, Russia, and maybe some of the African countries? Like if you know something about their situations, and more in particular about India, that, they had the lockdown about 2 months ago. And, a country that is like 1.3 billion people, they wouldn't just have a lockdown for no reason. But, at the time, they had very few thousand cases. And then now in Russia, which is now the third country with the most confirmed cases, that they have a very low number of deaths. Could you comment on these other situations?
And so I would do my best. And there's so many countries and things to keep track of. Let's start with, so when you look at India, for example, what you see there is a very heterogeneous outbreak where certain states have much more cases than other states, especially places like where the capital, or not the capital, their most populous cities like Mumbai are. They tend to have much more cases there. There is a real concern that they are going to have hospitals in crisis there. And you have to remember that even though a country may have a lockdown, social distancing is sort of a luxury. And if you are in a place that has high population density, many people who don't have any savings, have no ability to keep their food, they're not going, even if there is a lockdown, it's not going to actually have that kind of an impact because people are just going to go around it in order to survive. So I think that's important. These are that only certain countries, you can't extrapolate what happens in a high income country to another income country when you look at their lockdowns. With Russia, I think that there's been mixed data there, and I don't necessarily know that I actually completely have full trust of the data that's coming out from there. They definitely have a lot of cases, and I suspect that there probably is some data massaging going on there. We don't have the full picture in Russia. And I can't remember the third country you said?
The African countries.
Oh, so the African countries are going to be something that's very challenging because, again, that's another place where you cannot do this extensive social distancing and expect it to have an impact because there is not much savings. People need to get food every day. They aren't able to store it. They don't have the ability to do any of that social distancing. So we're very worried about what will happen in sub-Saharan Africa when this pandemic begins in full force there. And if you go back to 2009 H1N1, they were very disproportionately impacted in those African countries. So this is going to be a major issue. And I think it will be important to control the outbreak in those places because if we don't have a vaccine, if you've got the outbreak festering away in certain countries, all the other countries are also going to be at risk as well.
Thank you. I see, Betsy, you have your hand up, so you can go ahead and ask your question.
Okay. I'd like to know what your opinion is of the use of convalescent plasma in the treatment of the coronavirus.
Sure, that's a great question. So for those who don't know, convalescent plasma is taking the blood of survivors, which has antibodies in it, and then transfusing that into another patient to see if you get a benefit. Right now, this is going on in multiple trials around the country. We've had anecdotal evidence from China. However, a randomized controlled trial was just published from China, which did not show a benefit. There are some ongoing randomized controlled trials going on in the United States, which we're hoping to see. There are many sites around the country, including at Johns Hopkins and University of Pittsburgh, two places I'm affiliated with, that are doing this type of work. I think there is a lot of hope around it. I don't know if it will work. I don't think that there's any harm. They haven't shown any harm with doing it. And oftentimes, convalescent plasma is a bridge to a more sophisticated product, meaning finding which antibodies in a person's blood are really effective, and then turning those into monoclonal antibodies, which are basically a drug product based on those antibodies. And there are multiple avenues for doing that. And we know that that type of antibody-based therapy with monoclonal antibodies was highly successful in the Ebola and really changed the whole mortality rate of Ebola. So there is a lot of promise. Everybody's eagerly waiting the convalescent plasma trial, more of the results. Just a couple of days ago, the Chinese result came out, and it didn't show any benefit, but we have bigger studies going on right now in the United States that hopefully will give us more information.
So I have a question regarding contact tracing programs. The city of New York is collaborating with various companies to hire people that will, about 5,000 people that will track COVID infections, that will report to people who have been exposed and try to figure out who they came into contact with. How effective do you think programs like this are, and is it worth pursuing such an effort?
So contact tracing is kind of a core feature of public health, and it's not like we're just reinventing contact tracing for this coronavirus. Health departments do it all the time for measles cases, for tuberculosis cases, for HIV cases, for any sexually transmitted infection. So this is sort of bread and butter public health. The thing is that there's so many cases because of this virus that you need to build up contact tracing. So if you can get your contact tracing in a position where they can handle all those cases, or even a high proportion of them, and identify those people who are exposed and tell them to keep themselves away from people for 14 days, test them as necessary, monitor them. That will be really important, because what happened early on in this pandemic is we weren't doing that contact tracing at a very high degree, and all of these undiagnosed and unrecognized chains of transmission just were going on all over the place, like in New York and in Washington and in Santa Clara, California. And they basically ended up bubbling over into our hospitals. And that's what got us into that crisis, where the only thing that we could use were the governors thought they could use were very blunt tools like economic shutdowns, when ideally what we should have been doing is contact tracing from the very, very beginning. And that's something that we want. Now we've gotten to a point where we can actually push reset sort of and get to the way we should have managed this outbreak back in January and February. And so I do think contact tracing can be very effective, but only if there are enough contact tracers and they're not overwhelmed by the number of cases, which again is why mass gatherings are a very difficult thing, because you can imagine how difficult it would be to deal with the number of cases of exposures that might happen at the Super Bowl, for example.
Yeah, that's helpful. Thank you. The next person to ask their question is Ricardo.
So could you comment on what is your overall analysis on the number of deaths so far? Like, what do you think of this situation? Is this like a positive thing? Is this like an okay? Was this a catastrophe? And could you also comment on what is expected to be the number of deaths caused by the lockdown, particularly in poor countries?
So the number of deaths in the United States is we're over 100,000 deaths. I think that this is something that most of us expected from the beginning, just based on what kind of a virus this was and what type of case fatality ratio we were seeing. So I do think it is a definitely high number. It's bigger. It's almost twice some of our influenza seasons that we've had in the past. So this is something that isn't anything to be celebrated. I think it would be higher though if we would have went into crisis in certain places and hospitals had to ration care. So I do suspect we're still going to see more deaths occur, and it is going to be a pandemic that was worse in numbers than the 1968 influenza pandemic, for example. What do I think about the deaths from the lockdown? That's a complicated question, because each country's lockdowns were very different. So I don't even like to call the United States a lockdown, because it was almost like an economic shutdown where they stopped some essential services, but it wasn't like, for example, in England, where you had certain periods of time or you could only walk your dog during this period of time, or certain people were not allowed out of their house at all. Those types of places are going to see very disparate results from their economic, from the lockdowns that they had. It's going to take some time to actually calculate it. In the United States, I think we probably won't see a big tick of the numbers, because it's gonna take some time to see, and it's going to be specific to certain diseases. So it might be that some people's colon cancer got diagnosed later, or some people's chemotherapy got delayed, or a surgery got delayed, or they didn't go to the hospital for a heart attack, and that's going to take some time. But remember, you also have to subtract, because if you look at the United States, our deaths from car accidents went down a lot. Our deaths from murder went down a lot. So it takes some time from a health statistics standpoint to see exactly what the impact was and what on balance it was. But it is very clear, because the crime numbers went completely down, and now they're going back up, and violent crime is going up as these things are easing. So it's just not going to be a linear type of thing. But there clearly were costs involved, and not enough people were talking about the costs when they did this, and they really were very blanket and didn't necessarily have to be in some countries, but it's very varied. And I think when in the United States, people always say, well, why do we still have cases? Why are we still having 20,000 cases and we have all these economic shutdowns in place? It's because our economic shutdowns were very leaky. You could still do what you just couldn't go to restaurants and do certain things. You couldn't work, you couldn't do that, but you could still go outside, you could still do things, and it wasn't policed in a very big manner. And many of the European countries where they got their cases down all the way, they're just now opening to the place where the US was at the worst in terms of the most restrictive part. So it's important to keep that in mind, that they weren't completely homogenous across the country, across every country.
Thanks. Margaret has a follow-up question. Margaret, I asked your initial question before you joined the Q&A, so you can see that in the recording when I post it, but you have another question here in the chat. When I think about my family risk, there is some benefit to waiting due to all the improvements you mentioned, but ultimately, short of a vaccine, they all feel marginal or incremental to a relatively low-risk family like mine. My approach is to stay fairly isolated through September, but then to send my son to school, assuming things don't get worse, as the benefits to me outweigh the risks. And I don't really see what could materially change, let's say, in the next academic year. Am I on the right track?
So it's hard for me to answer your specific question on your specific life, because it really...
sorry, can I just chime in? I'm sort of using the framework presented by Emily Oster, which was, if you're thinking of doing something now or within the next month or within the next 6 months, if you don't expect anything to change, do it now. So I don't know if that's a valid framework, right? She's sort of saying, well, what's your alternative? Like, would you not send your son to school ever? So if you're going to send him to school, and you're going to send him to school at some point, what are you waiting for, right? So that's kind of how I'm trying to think about risk. And is that a good way of thinking about risk in general, and then specifically about this issue?
I think it is. I think that it is a good way. And often people say, can I do this yet? And I always say, why are you saying yet? Nothing is going to change. If you ask me if you can, you're going to ask me the same question again next week, and nothing is really going to change. This virus is with us. It's established itself in the human population. It's going to be a risk that we have to deal with every time we do something. And until there is a vaccine, that's going to be the case. So I don't think that, when people say, can I hug my grandmother this week, or should I wait until like 2 weeks from now? It's the same risk is there. So I don't think that there's any way to really think about that other than to know that, remember, in your first question, you talked about social distancing because of hospital capacity. And that's what it was about. Now it's going to fall to individuals, their own risk tolerance, risk preference, what their risk factors are for severe disease, to decide what to do. And it is important to know that every social interaction is going to have some risk of risk of transmitting or acquiring this infection. And you're going to have to decide yourself what the risk is, the risk tolerance you want to have in your life is. And for some people, they're very risk tolerant. So they're going to be going about their life just as if they were before, as close as they can to before. For other people, they're going to continue to shelter in place and really be socially distant. And I don't think that there's going to be a black or white answer to this. It's all going to be shades of gray. And, for me, I'm pretty risk tolerant. So I don't really necessarily, and I take care of patients with this. So I'm kind of a little bit, I said numb to it all. I don't necessarily, because I'm seeing people with it. But our restaurants opened in the Pittsburgh area, and I was at a restaurant yesterday. So it isn't. So and that might not be the decision that other people want to take. And I really I think you have to look at the risk factors. And there's obviously things that you're not going to be doing, like necessarily like mass gatherings, or you're not going to have the opportunity to go to a Baltimore Orioles game and be sitting in the fans. They're not going to happen. That's not going to, those types of sporting events and big mass gatherings are probably going to be off the table for some time in most places until there is a vaccine, unless they come up with a creative way to socially distance. But I do think that you can do lots of things that are relatively safe, that are around people, and based on your own risk tolerance, you can take whatever measures you want to do with hand washing or wearing a face shield or whatever it might be. I think that you're going to see different people approach this in different ways. And I don't think that there's a right way or something that I can proscribe. All I can basically do is tell you what the risks are, and you have to evaluate that in your own, with respect to your own quality of life and what activities you want to do and what's important to you and what's not important to you. And it's going to be, and like I said, it's going to be very individual. And that's where we're going with this pandemic now.
Thank you. I think the next person in line is Puya. If you would like to unmute, you can go ahead.
So my question is, what health consequences the current protests in US would have? And if the consequences were not turn out to be not so dire, does it prove anything?
Sure. So this is a good question. I've been getting asked it a lot, and I think Jack wanted to hear the answer to this as well. So a mass gathering is a mass gathering. There are going to be opportunities for the virus to transmit, especially when a mass gathering involves shouting, yelling, and chanting and screaming, because that's going to create more droplets. It's also the case that some of these protesters are getting hit with tear gas and with pepper spray. That also makes you cough. So we are very worried from a public health standpoint about what this will do in terms of, are we going to be able to contact trace? And we are already putting out recommendations that if you're at a protest, you need to probably stay away from people for 14 days and have a very low threshold to get tested if you get symptoms. We don't know what the impact will be. We won't see that impact probably for 10 days or so based on the incubation period, but we do expect to see an uptick in it. This is the same issue with protests that happened earlier on with the lockdown. So anytime you mass gather, this is going to happen. It's a simple biological fact. Hopefully this will be kept to a minimum. Hopefully this will be something that doesn't inundate our hospitals again. But I am worried because places like the Twin Cities, which had a lot of protests there, they were at their peak ICU utilization capacity just prior to these protests and the events that occurred there. So this is going to be something that we're all watching really closely because it could have an impact.
Julian, you are next online. You can go ahead and ask your question.
Hi, Dr. Amesh. My question is, what do you think of the idea that the lockdowns are not the best approach to the virus, and that instead, like, allowing the virus to spread and create herd immunity, while at the same time quarantining and sheltering the elderly and vulnerable and highest risk is a better way?
Sure. So the important thing to remember is that nobody in public health thinks lockdowns are the best way to deal with this. The only reason that happened is because many countries had chains of transmission that spiraled out of control because this wasn't acted on aggressively enough. And that's definitely the case in the United States. There was no plan to do any of this. But when New York City got hit pretty hard in early March, it became very scary for a lot of people. And I think in New York City, if you wouldn't have done anything, you would have seen the healthcare system likely collapse there and more deaths occur from other conditions. Then basically people took that experience in New York and extrapolated it to the rest of the country. And it really wasn't extrapolable to the rest of the country, but people took some time to know that. And politicians are very risk averse and they did not want to risk being blamed for anybody dying from this. So they all kind of went that way. But lockdowns are never considered the most effective way to do it. Voluntary social distancing is one thing and recommending to do that is one thing, but nobody wanted to do economic shutdowns for this long of a period of time. And we were basically, people were put into that position because of mismanagement early on. I don't know that letting a virus like this, which can have a mortality rate of about 15% in those elderly age groups, that if they get hospitalized, if you can go this herd immunity route, because I do think I've advocated cocooning elderly people, and I think that's really important, especially in nursing homes, assisted care centers, places like that. But you have to remember that there are many community dwelling elderly that are going to be hard to do that to. You can definitely do it at a nursing home, but not everybody's going to do it. It's hard to do. There are ways to do it, and I think we should have been from the very beginning We knew that there were this group of individuals that were at much higher risk for severe disease and much more likely to be hospitalized and use hospital resources. We should have been trying to, at that point, telling high-risk groups, you need to basically fully social distance as much as you can. We're going to set up services that there's going to be volunteer services to bring you food, to bring everything you need, and then sort of let the economy go. But I think we never got to that point because it got very, very bad very quickly, and we didn't know who was infected and who wasn't infected. So we had such a horrible time with testing that it was impossible to have such a precision-guided type of response, which is what we expected we would have. That's why many of us early on said the United States will be able to handle this. We never thought that it would get so that the diagnostic testing and the testing protocols of only testing people with severe disease and only testing people from China would actually be our policy. And that was our policy for way too long, and allowed all of these cases to accrue that we didn't even know about. And then it became too late to use any kind of precision tool. And that's why the economic shutdowns occurred.
Thank you.
Okay. I think Magat is next, so you can go ahead and ask.
Thank you. In the case of a vaccine being offered to the public, what are some of the factors you should consider if you should take it or if you should wait and see? Are there situations where it would be in your self-interest to wait rather than just take it?
So when the vaccine comes out, hopefully we're going to have a lot of data on what the side effect profile is and how beneficial it is. And it's not, remember when this comes out, it's not going to be that it's just all of a sudden available for every person. It's likely going to come out in tiers, and it's going to be healthcare workers and high-risk individuals who are likely offered the vaccine first before the general public. And we will be accruing data all that time to understand what the side effect profile is in different segments of the population. So I would take all of that into consideration when you look at the vaccine. And I suspect I'll probably be one of the first people to get the vaccine once it's available. But that may be different for other people. And I think we'll really have to look at the side effect profile and see where the risk is, where the benefit is outweighing the risk. And hopefully we'll have robust data to be able to help people make that decision. But that's generally how I would approach the vaccine.
Thanks. Next, Margaret, you can ask your question because I think that's a very interesting one.
I was just asking, Amish, what's the question you feel people should be asking and aren't? Like, what are we as non-professionals not thinking about?
And I think that there's two ways to answer that question. Two things. One is, how do we prevent this from happening again? Why did this happen the way it did? And why are we left in the situation we are in? And I think I've argued that a lot. And in my Medium piece that was published, if you look that up, I talk a lot about how the early stages of that that was there. And then the other question is sort of what you've been asking: is how do we think about this going forward, and how do we protect ourselves and pursue our lives at the same time? And that's a question that I can't answer for most people. I think it's going to be very individual based and hard. I think that's the biggest question that we have, is how do we live with this virus as a looming threat over us? And I think that there's not a good answer to it. But we're learning every day and getting better at it, but it's not. This is a non-zero risk for everything you do, and I think that's something that most people have not had to deal with, and makes it very hard for me to actually proscribe how someone should do this or not do this, because I get asked by the press every day, is this safe? Is this safe? Is this safe? And my answer is everything is relatively safe or unsafe, but nothing is going to be ironclad.
Do you have to get going now, or do you have time to take one more question?
I could take one more if you want.
Okay. Ricardo, you can unmute and ask your question.
So could you comment on the current state of testing? Are the testing is that still going up? And looking forward, do you think being tested is going to be a thing?
Testing is increasing substantially across the United States and across the world. In the United States, we're doing about 400,000 tests per day. That doesn't mean that every person needs to be tested. We really want to test people who have symptoms. We weren't able early on to test people with mild symptoms, and that's how we got into this mess that we got into. So now anybody that needs a test and whose doctor recommends a test should be able to get a test. And that's what we wanted to get to. People who don't have symptoms, we do test them if they're part of an epidemiological cluster or a link as part of contact tracing, or some hospitals are doing that when they're bringing in people to do procedures. that's not uniform. But that's basically where we are with testing. We want it to be seamless so that you can get a test very, very easily. And I think we're at that point. We're getting better at tests. We're going to probably have more rapid tests available, hopefully soon, hopefully point of care tests, that we can just do this very, very easy at a doctor's office. But it's not the idea that we need to test every member of the population all the time. That's the wrong way to think about testing.
Okay, so I guess that finishes up this Q&A. Thank you for coming and joining us. And Dr. Adalja, I know you're very busy right now. And thank you everybody else for asking intelligent questions. I've learned a lot from this.
All right.
So yeah, thank you for attending and have a good rest of your day, everybody.